respected chairpersons, dignitaries, faculties, and attendees. A very good morning. At the outset, first of all, I'd like to thank Dr. Sandeep Jasuja and team for giving me the opportunity to be here amongst you all. In the next 15 minutes, I'm going to speak about the rationale and techniques of IMRT and organ-sparing approaches in the breast cancer radiation therapy. So as we are all aware, radiation basically is used in the breast cancer cases to reduce the local recurrences and is associated with improved survival. However, there's always a concern regarding the treatment-related morbidity in the breast, as well as the long-term risk of heart and lung disease. And that is why it is a need of time to optimize radiation to have maximum effect and minimize morbidity. And that's why we see in the last 2-3 decades, we have seen a huge transition from the 2D era to the 3D era, where we have shifted from the bony landmark-based planning to the computerized planning of the individualized target. But we should not forget that the basics would always remain the basics, where we have to understand the patient's body habitus. We have to understand that if it's a high BMI patient, we need to decide the arm position, the elevation. We need to check for the patient's arm movement. If there's any lymphedema, we have to document on the day one. Type of the breast, sometimes in the pendulous breast, we have to identify and reduce the folds, and the location of the tumor also needs to modify our conventional borders. Always consideration to the preoperative clinical findings is a must, where we see what's the location, size, is it involving the NAC, what is the lymph node status, and the histopatho report. So this is what the era we began with, the 2D planning era, where it was the contour taken at the central axis and the dose distribution calculated. A very good technique, simple, time-tested, and a good reasonable sparing of lungs and heart. But what we realized was that the acute and the late sequelae was quite huge, where we see the acute as a skin toxicity, mostly the inframammary region, and which resulted in treatment break, impairing the quality of life, and most importantly, in the patients who had a large breast size or where there were hotspots were seen as more than 2 centimeter cube of the 107% of the prescription dose. As far as the late sequelae is concerned, it was the cosmetic outcome being affected, seen in the 25 to 40% of the cases, or the heart and the lung disease. And that's why came the era of IMRT and the conformal treatments, because we now try to make the treatment more and more specific only to the target and lesser to the critical structures. This is the era of modern technique I'm talking, where we have a huge armamentarium right from the 3D CRT, IMRT, tomotherapy, electron, and today we are in the era of proton therapy. So the basic step remains the same for all cases, where we do the CT simulation. It's a position given which should be comfortable and reproducible. Supine position majority of the times, using simple things like a breast wedge, which can help us in sparing the critical structures like heart, both the arms above the head, so we don't have any disturbances, and most of the times it's a plain scan. So when I say the 3D planning, is it that all patients don't need 3D planning? So this is a very interesting paper by Munshi et al., who tried to study the differences in the dose distribution from the superior to the inferior slice, and what was being seen as the small breast would not have much difference, say about 5% only, but the medium and the large breast were the ones where the dose distribution changed significantly, especially in the large breast, where from 9% to 15%. This is how is a 3D planning looks like, where the patient is first taken for the CT simulation and then the contouring done so as to have only the dose distribution to the target area. The IMRT was a one step ahead of the 3D CRT, where we had modified bitangential portals. We had multiple segments inside each tangential portal so as to have a more precise dose delivery and more dose distribution being homogeneous. This is the era I'm talking about, right from 2008, where we were very much convinced that yes, IMRT is very significantly helping us in reducing the acute side effects. This is a Canadian trial with 300 plus patients. And the acute skin reaction, when they were studied as compared to the simple 2D technique, we realized that IMRT can decrease the acute side effects with a significant p-value. The same was being seen for the late side effects also in the RMH hospital, where 300 plus patients, when they were studied for the late side effects, as compared to the traditional 2D technique, the IMRT could reduce the late sequelae with a significant p-value. A small introduction, what is basically called as forward IMRT versus inverse IMRTs. When we say IMRT as intensity modulated radiation therapy, when we decide the target, we decide the critical structures, and when we give all these constraints to the computer and let the computer generate 2-3 plans, and then we decide what is the best plan, that is called as inverse IMRT. Rather than forward IMRT, where the clinician themselves try to generate different beams, put weightage to the beams, and then see how the plan turns, which is known as forward IMRT. What we realized and what the scientific literature showed, that forward IMRT shows a better dose coverage as compared to inverse IMRT, for the reason that apart from having a homogeneous dose distribution to the target as well as to the lesser dose to the critical structures, there was a concept called as 5 gray volume. That is the volume which receives 5 gray. And it was being realized that in the forward plan IMRT, the 5 gray volume was less. So if we talk about the IMRT, it is the forward IMRT which is far better than the inverse IMRT. And when I keep on repeating that IMRT, does that mean that every patient is a case for IMRT? So there are very crisp and clear guidelines from the Astro which says, no, it is not. Most of the times, the small size would not need an IMRT. Even a simple 3D CRT would be the best. But mostly in the medium size and especially in the large breast size with more than 1000 cc, IMRT should be considered. And as I said, whenever to be considered, the forward IMRT has to be used rather than the inverse IMRT. Of course, we are in the era where we talk about the critical structures being spared, like the cardiac sparing, and there the gating and the image guidance is a must. So these are some dose distributions we calculate to see that the ideal target is getting the perfect dose and the OA is getting the minimum dose. But when my title of the second part says organ sparing, I think I would have quickly few slides running through the cardiac sparing. That is, how do we spare the heart, especially in the cases of the breast cancers and especially in the left-sided ones. So there are different techniques of sparing, heart sparing, like breastbone, prone position, and the techniques. I'll go one by one. The breastbone, something makes your treatment change from this, the first picture where the patient is lying supine. And here still you can have some amount of dose being bombarded to the heart and the lung as compared to a breastbone, which will make the patient a little bit inclined and help the tissues move forward with lesser inclusion of the tissues deeper to the chest wall. And from the evidence, it has been realized that most of the times the mean cardiac dose can even be reduced by 60% sometimes, and the maximum dose to be reduced by 30% with a simple technique, note that is keeping a breastbone. Another simple maneuver is the prone position, where this is a type of the board we have, and there's a gap in between where we allow the breast to fall in. And what makes the breast moves very much far away from the critical structures, and we can have the heart sparing. There are papers with 200 plus women experience showing that the volume can be reduced in about 85% of the times. But the main problem with the prone breast is the most common limitation what we have seen is a little bit of difficult position, because there's a lot of stress on the neck and the spine muscles. And secondly, this breastbone is a little bit huge. So normally the routine diameters, the CT bore diameters, they would not comply this board to go in. And of course, as I mentioned, the patient weight and the knee issues can also be concerned. So then from the simple things, we then move to the era of the 3D techniques and the 3D era techniques. And if I just summarize the different dose volume histograms of different techniques, that is 3D CRT, forward IMRT, inverse IMRT, tomotherapy, it is seen that the helical tomotherapy results in the lowest heart and the ipsilateral lung max doses. And as I said, out of all these plans, the forward IMRT fares better. What is called VMAT or a rapid arc, it's a novel extension of IMRT where we try to treat the radiation in a single arm, that is in a single gantry rotation. It's like a CT scan sort of thing, which helps in reduction in the treatment MUs and making the treatment faster. So the patient compliance is very good. Apart from this, there are certain techniques which is very commonly known as deep inspiration breath techniques, DIBH. I'm sure many people would have come across this terminology. This is a technique where we are trying to eliminate the motion. We are increasing the lung volumes, pushing the heart away from the chest wall and the radiation fields. And if you see the two main important vendors in the radiation, that is the Electa and the Varian, they have different maneuvers for doing this DIBH. In the Electa, it is called the ABC system, and in the Varian, it is called the RPM. What happens in the Electa ABC system is we have a mouthpiece with a filter, a spirometer with a closing valve, a nose clip, a breath controlling trigger, and probably these all that are connected to the software and the hardwares, which will screen and show the respiratory pattern. And after what we have decided, the radiation will be given in that pre-decided respiratory pattern only. So this basically needs a lot of homework, because before we do the simulation, we need to train the patient. We need to ask the patient to take the breath, hold it for the maximum amount of time the patient can hold, sometimes say 20 seconds, 30 seconds, make the patient counsel for that, and then we take for the CT simulation. And as I said, it is then transferred, the respiratory pattern is noted, and then we decide the treatment. What happens in the Varian RPM system, that is a little bit simpler, because we have a small 6-marker neon localizer box, which is kept on the chest wall. There are infrared cameras and lights which are observing this. And there's a hardware again to observe respiratory pattern, and there's a link with the linear accelerator which will start and stop the treatment. So this is something, it looks like this. This is the neon box I'm talking about, and then the infrared cameras, they capture the motion of this. If you see the pros and cons of both the things, what happens in the Elekta system is there is a mouthpiece, there is spirometer, so we can help fix the volume as per the patient's capacity, what counseling we have done before. There's a breath control trigger which will ensure treatment disruption in the event of unexpected situations. And we have seen that there's a higher reproducibility in the Elekta system. Whereas in the variant RPM, what I'm talking about, that's a very simpler one because there are the infrared rays which are depicting the movement of the chest wall by localizing that box. And there's a mechanism where automatically the beam is on and off if the threshold is not being met. So it is like a gating of the beams. What are the downfalls of both these techniques in the ABC? As I said, there are different small things, the mouthpieces, the nose clip, which can be a little bit uncomfortable. There's leaking of air from the side of the mouthpiece, and this equipment sometimes can also obstruct the gantry movements. And in the variant system, since it is a very simpler one, but there's another one problem, which is that we don't have any mechanism to help patient hold the volume for the duration fixed. What literature has showed that as far as the reproducibility is concerned and the dosimetric benefit is concerned, it is comparable in both the arms. So it depends upon what machine you have, and then you can decide whether you will go for the ABC technique or you will go for the gating or the RPM. But the important purpose of doing all this technique is that, yes, it has translated in showing reduced heart doses, reduced lung doses, and a better target dose distribution. Now, when I talk about IMRT, what one more advantage we get with the IMRT is the hypofractionation. That is, we are in the era where we try to say less is better. So we have seen that even the breast tissue has a unique alpha beta ratio, and that is why it is quite sensitive to high dose per fraction. And there we can dare to give more than the conventional 2 gray. And that is why if you see, there are many centers who have a good advanced machine, they'll be doing hypofractionation where they give radiation only for 15 fractions or 16 fractions, depending upon the institutional policy, as compared to the routine what we were doing of 25 fractions that was going up to 5 weeks. And it has been very well proven that there is no difference in the local recurrence or the local regional recurrence or the disease-free survival and the overall survival with the hypofractionated. So even my clinical practice is to do for hypofractionated radiation only. Now we are in the era where we are moving more one step ahead from this. That is the more hypofractionated, which is called the fast forward trial, where we are trying to complete the treatment only in just 5 fractions. And the initial results, what we have seen, has found to be very much promising, because the ipsilateral breast tumor local relapse has been shown to be similar. But I think it is too early to comment upon and wind up and say that fast forward is the future, because we don't have any comments right now on the late sequelae. Of course, the initial results are very promising. It is reducing the overall treatment time. It is a good boon for the patients where the facility is quite heavily workloaded. Like say, for example, a tertiary care center or a government center who has a huge workload, their fast forward can be really a boon. But as I said, we don't have the late data, so it is very early to say and wind up that fast forward can be the real thing. So we have to wait at least for about, say, from today to 2030 to decide that fast forward can be there. So to end and to conclude my talk would be that we are sitting in the era of the conformal planning, where we have seen that IMRT and the conformal 3D planning is really very important, and it has shown the benefits, but the imaging is always the backbone. Also, the backbone is the basics which we should not forget. And ultimately, our aim is to have the best conformality, best cost masses with minimum toxicities and a shorter period of time. I thank you for your patient hearing and would be happy to take any questions if they are.
Thank you, Dr. Pooja. Wonderful talk. I think a lot of new things are going to come in. Probably you're going to have a membrane or anything that you'll tell the surgeons to put in to prevent the heart from getting the radiation. I think newer things are definitely going to come in, but wonderful talk. Very nice. Thank you.
Thank you.
We've had a very nice session. If there are any questions.
Pooja,
yes,
for left-sided HER2 positive early breast cancer, not negative early breast cancer, what is the better option? Breast conservation versus skin sparing mastectomy without radiation?
I think.
Yeah, you can answer, but what is the better option?
I think Dr. Somshikar, you can take this, because this will be really a...
Because
I don't think in the era,
everything is cardiotoxic. Anthracycline, then radiation, then transdermal.
No, that's why I think
Everything
we
is
are
cardiotoxic.
making it trying to be less cardiotoxic, but I think we are still not in that stage where we can really omit radiation, especially in the BCS cases.
No. So that's why I'm asking
Yeah.
breast conservation versus skin sparing mastectomy without radiation.
I don't think I will have an answer to this right now. Maybe Dr. Somsekhar can throw some light on that.
Well,
I know.
just a
He'll make it
short-
more confusing.
Just a short question. Nowadays, the thinking is that even 3 weeks of radiation is good enough. Is that really true?
So it not does depend upon the beams, because as I said, we have to decide how many beams, what is the weightage of the beams, and where today we are also in the era of we are doing the arc therapy, that we are not just doing the beams, but we are trying to complete the radiation in one arc only. That can be either a 180-degree or a whole 360-degree. So it is just depending upon what we are using and where best conformity, best homogeneity we are able to get. So it is not just the number of the beams, even we are good enough with the arcs today.
Because that can change everything. Like people used to say after breast conservation, you need 1.5 months of radiation therapy. If we just tell them, no, it's only 3 weeks, probably the acceptability of BCS would be better.
Yes.
Thank you, Dr. Pooja. We've had a wonderful session. Dr. Vikas, Dr. Pratik,
Thank you.
Pratiksha, Dr. Pooja, they've done a wonderful job. My co-chairs, Madam Sumita, Dr. Sanjeev. We've had advances in medical oncology, advances in imaging, and advances in radiation therapy. And now I can see the surgeons itching to take over the wheel. Dr. Somsekhar, please, next. Thank you.